All right, welcome everybody to the Ultrasound Grand Rounds. We're coming back at you this fall term, 2023. Hope you guys had a spectacular summer. For those of you guys who were watching on the YouTube channel, we've been kind of trickling out some lectures over the course of the summer just to kind of keep things going. But for those of you guys who are just joining us back in on the Zoom side, welcome back. I hope you had a great time. So we are going to get started this semester with just some really fun and exciting topics. I always like to do kind of an overview topic first, and then we're going to dive into some things. So with any luck, that's going to be the pattern. I'm excited. The next couple of weeks, we have some really good speakers lined up. I got someone coming next week to talk about ultrasound and AI. And then in a couple of weeks, we're going to have someone coming in talking about the transesophageal echo in ultrasound. And we'll scatter in some other topics in between there. So if those sounded interesting to you, we'd love to have you continue to come back and definitely continue to share this forum either on the YouTube channel or the Zoom link with your friends. And we can hopefully grow this opportunity in this platform. So with that being said, let's dive right on in. We're going to talk a little bit about an overview ultrasound topic today. And today we are going to be talking about POCUS and patient value. So this is a topic that I thought was kind of interesting. Something I wanted to bring to see kind of how we can use POCUS to improve value. But it all started with a book, right? So I read this book over the summer. I actually heard a podcast with this author, Dr. Marty Makary. He's a surgeon out at Johns Hopkins University. And he has done some writing about, healthcare financing and kind of quality, value, things like that, right? And so this book he wrote was called The Price We Pay. Its subtitle is What Broke American Healthcare and How to Fix It. So this is obviously a huge topic in medicine in general. We're always looking at, how do you best administer a healthcare system? Not just how do I get healthcare to the individual patient, which is highly important, but how do you just kind of set up a system to efficiently optimize, our, patients getting seen, patients getting cared for, and providers getting paid, right? And so this is, definitely a big topic. And I don't want to go into the political details of, do we go for a market-based or a single payer-based? That's really not the idea of today, and certainly is not the goal of this book either. But it's saying, hey, what are the drivers of cost? Because I think the presumption here is we live and we exist in probably one of the most premier healthcare systems in the world in terms of outcomes of care. And we can make some arguments around the edges of, well, the Canadians do this and they get a little better outcomes here, and the Australians do this and they get a little better outcomes here. But I think if you want to be sick anywhere in the world, the United States is probably the place to be, because we've got the resources to do it, to manage it. But the question then becomes, how do we get those resources to the patients in ways that the patients can, afford and access? And how do we optimize the value that a patient is getting? So when you go into the healthcare system, when you say, hey, I need to see a doctor, right? How do we make that experience something that's not a pain in the rear, and you can get the stuff done that you need to get done, right? And so this is kind of where the book was talking, or what the book was talking about. And so Dr. Makary and his team identified a number of factors that increased or add to costs for healthcare, right? And some of those are, over screening for things that don't need screened, right? Which leads to downstream testing. We've talked about that, not in this forum per se, but I know we've talked about that in our residency education here in the emergency department. Like when we do unnecessary tests, it leads to downstream screening or downstream testing. So why are we doing this test that we're doing? Is it going to help the patient, right? The second one is kind of predatory billing. So are you, some hospitals go after patients, to the really to extreme ends to get their money's worth, or to get their money out of the patients. And it's definitely irritating patients, and leaving them financially devastated as well. And then, the obvious big elephant in the room is the fact that no one knows what a stinking test costs, right? When you order a CBC, we really don't know what it costs, because for every single patient, it costs probably something slightly different based on who's the payer and what that payer is negotiated with the hospital and how much gets reimbursed and things like that. And so there's really no understanding, at least I have zero understanding of, when I see a patient and I order a bunch of tests, what's it going to cost for the patient? And then, he talks a little bit about, like, are we adhering to guidelines? Your specialty has guidelines, or there's maybe best practices that we either have yet to discover or have been discovered, and are you adhering to these? And so he used the example of what is the C-section rate for individual physicians, and how can we kind of bring that down to a established norm, so we can get the outliers kind of outside of the excessive rates of C-section, right? And that will improve costs and improve quality for patients. And then there's some things that you can do with the different organizations that are kind of stood up around the healthcare industry, like insurance or pharmacy benefit managers or group purchasing organizations, all of which are necessary. You need to have brokers to help provide insurance to different businesses or individuals, and you need to have these PBMs that kind of help manage your formulary, or your GPOs that help manage the things that you buy. But each of those ancillary organizations that come alongside healthcare add a fee, right? And so each of those fees then increase costs. And so are those fees justified for the services that are being provided, or are they excessive, right? And Dr. McCary and his team identify in the book a number of ways and a number of organizations where these are excessive. And he also identifies a number where it's actually reasonable, and says, here's ways, before we even get to the whole, what legislation should we put in place to adjust our healthcare system, right? Before we even get there, here's some things that we can do to work on costs around the edges that are going to have a substantial benefit for patients, right? And so I found it a fascinating read, something that I definitely would encourage all of you to pick up and read. And, there's going to probably be some differences in opinion in terms of the relative value of each of the different items, or what to do. But it definitely is a great opener for a discussion, right? And the QR code there will take you to a link of a review that I wrote for the book. But anyway, that was the book that kind of inspired some of this thought in my own practice, as I approach patients, say, okay, I have these dueling priorities, right? Number one, I don't want to miss things. I want to provide the highest quality of care that I can get for patients. And I don't necessarily want to insinuate that adding extra tests or ordering more things increases quality, because it doesn't. But I don't want to skimp on things that are necessary. And I know that I'm going to have to cast a broad enough, in order to pick up what I need, I'm going to have to cast a broad enough net that some of the tests that I order in retrospect will be like, yeah, I didn't need that. In order to not miss the test that I do need, right? So there's that balance. Plus, balance with, how much am I going to cost the patient when I order this test, right? So I want to thread that needle of ordering enough, but not too much, but not so little that I miss things, and really infringe on the quality of that patient's care. And it really is kind of put in my head the question of what is value, right, for patients, and how do I really promote and encourage that value in my own practice, or get value out of the care that I render. And more importantly, when the patient leaves my department, right, and he or she gets the after visit summary with my name on it, and looks at it and says, man, this doctor who saw me really gave me something that's of value. And when I get the bill, I'm like, 100% earned, right? 100% well-deserved, because of the value that was provided through the care that was given, right? And so I think that's the goal, kind of, if you look big picture philosophical, like what is value? But it gets down to that question of, okay, what is that value? What is that thing that I need to do that improves value for the patient, so that I know how to do it, and know what to target and what to aim at as I'm seeing patients, right? And so if you go to the dictionary, and just want kind of a straight up definition of value, right? Value can be defined as the regard that someone, or regard that something is held to deserve, right? The importance or the worth or the usefulness of that something, right? And oftentimes we think about it in material or monetary worth, right? The material monetary worth of something. So this is total value of $500. It also has these connotations of the value of something compared to the price paid, right? And so there's definitely this: is the price reasonable for the services that were rendered, right? And is the service appropriate to the price, right? I know it sounds kind of like I said it the same way twice, but think about it. If you go to a fancy restaurant, right, and get a steak, it's going to have a certain cost, right? It's going to cost you $50, or you can get a hamburger that's going to cost you, $16.99, right? There's different value to that form of meat that you're ingesting, right? Now you can also say, that I went to this restaurant, got a $50 steak, and I went to this restaurant and got another $50 steak. It could be the exact same cut. Maybe it could even be cooked the same way, but there's a lot of other ancillary things around that increase the value. Was it served in a nice way? Was the presentation appealing? Did it taste good? Was it cooked, to perfection? Was the serving staff, courteous and kind and waiting after your needs? Did you get buns with the thing, or did you just get the steak? Like there's a lot of other things that go along that make us say, man, that $50 was 100% well spent because of the value that I received for that meal, right? And it's just an absurd example that just came to my mind immediately. But I think you kind of get the idea of, is this thing, commensurate with what we're charging? And does the patient feel that they got a good deal at the end of the day? Because at the end of the day, we want basically for us to be satisfied and that we provided meaning for our existence and purpose, for our existence, and know that we helped patients, right? And the patients want to come away knowing that they had something of value, right? And so as we kind of think about this even more big picture, one of the things that we can think about is if we view this purely in monetary terms, we kind of miss another aspect, right? And so I think we can kind of understand this other aspect is, what do patients want at the end of the day, right? What do patients value? And it's basically this concept of human flourishing, right? They want to go home, they want to live their lives, to be with the friends that they enjoy and the family they love, right? They want to be able to do the things that they really enjoy doing, and they don't want their health to necessarily get in the way. They want it to augment and allow them to do what they want to do, right? And so to the extent that we can align our priorities, providing that health service, right? There's things that I can do that they can't do. There's knowledge that I have that they don't have. So to the extent that I can provide that knowledge and those services to that patient in line with their priorities, right? What they want to do, we can create value, right? So to the extent that we are promoting human flourishing in a way that's valuable to the patient, then the cost that we charge will seem reasonable, right? As long as that cost is within reason, right? And so I guess this is the big picture idea of where I'm trying to go with this thing. And okay, forgive me, I'm waxing a little bit too philosophic on this one. But I think it gets down to the point of how do we then understand this value, right? Promoting human flourishing. And what are the factors that I have in my control, right? The buttons I can push, the levers I can pull that can augment or enhance the experience they have with me as a physician to get to that goal of human flourishing, right? And that's where we're trying to go with today. So as we apply value to medicine, there's 3 levers that we really have that we can pull that are going to help increase the value of the care that we provide to patients, right? And those are going to be the cost of care, the quality of care, and the efficiency of care, right? And so some of these are a little bit, some of these are very, cut and dry. Your bill is X, although as we've previously discussed with all the different payers in the payer mix, who knows what that bill is? And if you go, depending on what hospital you go to, depending on who your insurance provider is, that number could be two very different things. I could go now, again, stupid example, but it just came in my head. I could go get an appendectomy at one hospital, and I could get the same appendectomy at another hospital. Don't ask me how I got 2 appendices, but whatever. Roll with it for a sec. I could have those 2 different procedures done, and they could be 2 different costs, for the care that was provided, right? Same thing, same outcome, 2 different costs, right? You can also have 2 varying different qualities, right? You could have a pretty, amazing surgeon, or you could have a pretty crummy surgeon, right? You could have a high risk of, post-op infection. You have a low risk of post-op infection. So there's a lot of that, that goes into that whole quality thing. How do we measure quality? What are the metrics that we want to know? And then finally, the efficiency of care. So yeah, I need my appendix out. So I'm going to get this thing done, and I can be in and out in X amount of time at hospital A, or I can be in and out in, X plus whatever time in hospital B, right? And so as applies to, our care in the ED, things like that, how long does it take to get from hit the door to out the door, wherever I need to go? That's the efficiency of care, right? Or can I get to the diagnosis that I need to get to rapidly? Does it take me 4 hours to get to that diagnosis or 2 hours to get to that diagnosis? And so as we go through the rest of today's talk, we're going to try to talk about how point of care ultrasound, or POCUS, can have an impact in each of these 3 different aspects that lead to value, right? The cost of care, the quality of care, and the efficiency of care, right? And so with that being said, let's just dive right on in here. So the first one is cost of care, right? Can POCUS affect the cost of the care that we provide? And obviously, we're doing a thing, right? I'm taking some of my time. I'm using some of my expertise. I'm using a tool that I have in the department. All of those things are going to increase the cost that it takes, that it is to render care, right? And okay, maybe the cost of my time isn't much because the hospital's already got me here, right? But to use a tool, right? That tool is a degradable asset. And so that's going to cost something to eventually replace that, upgrade it, keep that, maintain that, right? So it's going to cost us something. And that cost is usually translated down the line to a bill to the patient, right? We're doing a service to a patient, and that patient gets a bill for that particular thing. And so is that bill going to increase the value to the patient, right? Can we leverage the tool that we have to ultimately decrease downstream costs, or is this thing just going to pile on another thing, and the patients are going to be, soaked with another bill, right? And so with that being said, let's look at a little bit of a case to kind of help illustrate this. So this was a patient that I saw not terribly long ago who came in just complaining of, I don't feel good. Like, I just feel really crummy and I'm not breathing all that well, right? And so what we know about the patient, dialysis patient, recently dialyzed, so it's probably not a factor there. Although maybe, the last known cardiac function, last echo, had maybe mildly reduced EF, but certainly not horrible, right? All of the lab parameters that we got in our workup were really close to within normal limits. There was a few things just on the periphery that was like, okay, it's enough that we're going to bring you into the hospital, but really not enough to explain why they're feeling the way they're feeling, right? And so did the bedside ultrasound, and lo and behold, all of a sudden now we find out that the patient has biventricular failure, right? The LV's down, RV's down, IVC's big. Now it makes sense to me why this patient is so short of breath, right? And so we can do a little bit of extra, testing here. We could say, the RV is a little bit big. That kind of goes into the biventricular part of the thing. And we do a little bit of Doppler through the tricuspid valve. We find out that they have, a pulmonary gradient of about 22 millimeters of mercury. Add that to about 15 millimeters of mercury for their IVC pressure, and we get somewhere kind of in the neighborhood of that 30-ish millimeters of mercury for the systolic pulmonary artery pressure. So it's a little high, not horrible. But it is kind of what it is. And we see that, TAPC shows that the RV is really, really down. And what this allowed us to do is then say, oh, wow, this is what's going on. This is what I need to hone in on. Let's start some diuretics and get this patient rolling, as opposed to just putzing around and kind of figuring out what I need to do, down the line, and kind of with a long series and battery of tests, right? And so what that brings us to is kind of a series of papers here that tried to assess how does point of care ultrasound affect cost for patients. And I think a lot of the effects are going to be in secondary effects, right? So this was it's actually a poster that's presented, but basically is using the, ED and ICU patients. They were looking at the RUSH protocol and the BLUE protocol, right? Performed, like I said, in those two respective places. And they said, okay, early, ED ultrasound ultrasound was performed, POCUS was performed. First off, the diagnosis we got, was it consistent with the final diagnosis? So is the thing decently accurate? And second off, what did it do for cost savings, right? And they found that 80% of the time POCUS was, congruent with the final diagnosis. And then they kind of looked at, what was done, right? What alterations were done, and extrapolated, and again, extrapolated. So we'll look at a few more papers that in this cohort, they saved about $80,000 worth of money, in terms of using that ultrasound to get to a better diagnosis faster, right? So paper is a poster presentation, albeit not a lot of robust data there. But if we kind of dive into some other papers, we can kind of see a little bit more of this theme picking up here. So this was published in the Journal of Ultrasound Medicine 2019. It's basically point of care ultrasound in a community emergency department, right? So community emergency departments are notoriously just like, we're busy, right? And so what they did is they said, okay, we're going to do ultrasound, right? Or have our providers do these ultrasounds, and then ask the provider what management steps changed as a result of doing the ultrasound, right? So they did their ultrasound. And then they said, okay, we're going to look up an up-to-date kind of what they would have otherwise done, right, to get a list of recommended tests that would have otherwise been ordered, and then run a cost analysis for what they would have otherwise done that they didn't then do, and see how much money they saved, right? And so in this analysis, they basically calculated out that if you were an insured patient, right, their average cost savings was about $1,100, right, based on the workup that was not done as a result of kind of the ultrasound giving you the answer faster, right? If you were a out of network or a self-pay patient, that was substantially more at $2,800. And if you're a CMS patient, you're looking at about a $180 difference, in terms of, saved costs. And so what they say, they concluded, is that when POCUS was applied earlier in the patient's care, right, as opposed to later on in the patient's care, you're able to get a better understanding of what's going on faster, and they're able to avoid costs, right? And so I think another example that kind of resonates with me in my practice here is saying, okay, you have the patient that comes in dyspneic, right? Acutely short of breath, they're working hard to breathe. It could be a number of things, right? Maybe their blood pressure's up a little bit, their heart rate's up a little bit, they got a history of heart failure, they got a history of COPD. What direction are we going to go, right? If we do a bedside ultrasound, we can see heart function is unchanged. We got, A lines on the ultrasound. This is pushing us more towards the COPD, route, and we're going to focus our resources there as opposed to going all the way down the heart failure route and realizing we were wrong, and save some time, save some money on this patient, right? So that's kind of, it intuitively makes sense. There's a few problems with this study, and just to be fair, right? It assumes what the care would have been. So it's kind of hard to say, well, we did this thing, right? We saw this patient, we did this ultrasound, we modified our care from what we were maybe going to have done. And then kind of let's extrapolate what would have been done. So it's hard to say what would have been done had you, as Robert Frost says, followed the other road, right? The road, you follow the road less traveled. If you want the other one, what would have happened? So that's hard to do. I think they did as good a job as they could have in the context that they were in, but it's challenging, right? And it also, the other limitation that I see to the study is that there's complexities in the system that makes it hard to generalize the care that was rendered. And so is this $1,100 applicable to my hospital? I don't know, maybe. I think it's plausible that the results would hold up, but it's hard to say that the results would hold up to the exact numbers with any form of, of specificity there. And so interesting idea. Leads us kind of to our next paper. It was published a couple years later, Journal of Ultrasound Medicine. And basically the point of care ultrasound use and monetary outcomes in a single payer health system. And again, these QR codes will take you a link to the article if you want to read them yourselves. But this one was kind of interesting because this was done in Canada, right? And so we've got some international listeners that are following the YouTube channel, and they say, okay, great, Matt, so you're in America, right? And your healthcare system is very different than mine, right? And so how does this apply to mine, right? And so again, this is maybe generalizable only to Canada, but it kind of gets us an idea of what kind of things look like in more of a single payer system. And they basically did POCUS in the ED, right? And they recorded the workup. And what was interesting, they did a little bit different in this study compared to the first study, is they said, okay, we have these patients that you did ultrasound on, right? We're going to see what you did, right? And then we're going to take that patient presentation and go to one of your colleagues who happens to be working in the department at the exact same time, unrelated to the care that's being rendered, right? Unrelated to the actual patient care, and say, okay, Dr. So-and-so, here's what someone else is doing. We're not going to tell you what the ultrasound said, right? What would you do in this situation? And they got the workup that was performed by the, attending of record, and they got the workup that was, proposed by the non-attending of record, and compared the two, right? And calculated the cost differences, and they converted it to US dollars. So I guess it makes sense for us, right? And what they showed, and I thought was interesting, is that there wasn't a statistically significant difference for all comers, right? But there was a trend towards cost savings, right? And I don't remember exactly how many patients they had in here, so there may have been a power issue, because I think they selected 40 patients for the total cohort. But I think it's consistent with what we saw, in the previous study, that when you look at the insured versus the uninsured versus the CMS rate, right? We saw a $181 difference with CMS versus $1,100 with the insured. And so if you go to more of a single payer system, right, where the prices are going to be more managed by one payer, right? I think it's, you're going to have probably a diminished cost effect. However, I think the POCUS, at some point is going to provide some, small savings towards cost, right? And so one of the things that the limitations of this particular study is that the cost differences are likely going to be very, very much different when you have a variety of payers or in your payer mix. But they did show that there was a trend towards cost savings in the patients that got ultrasound. And so I think taken together, all three of these, I don't think we're going to solve the healthcare crisis, in terms of cost. But based on the available data, it appears that the early use of ultrasound in the ED does provide some degree of cost savings, right? And this seems to be, like I said, somewhat variable based on your payer. But I think it's going to be, the numbers are going to continue to be there. And so I think the takeaway for us is that point of care ultrasound can provide some benefit in terms of cost to the patients, right? And I think this really comes down to a couple factors, right? This comes down to, if I do the ultrasound, in select areas, right, I don't need to do a whole battery of further testing, right? So I gave the example of the COPD versus the heart failure. Maybe we'll extrapolate that out to another entity that causes dyspnea. If I do a scan, I know their previous cardiac function is normal, and I scan them, and all of a sudden I find, a diminished, a severely enlarged and diminished RV function. Well, that may push me down the PE route a little faster than I would have otherwise gotten there. And I can maybe short circuit a lot of the tests by just going directly and ordering the CTPA and the other tests that are necessary for PE versus, do I explore the COPD route? Do I explore the CHF route? Taking a lot of extra time, to do those things. So there may be some decreased need for downstream testing. And, to some extent, and this is going to be a little bit of a, maybe a little bit of a place we got to be a little bit careful just to be collegial with our other colleagues, but can I order a cheaper test, right? A limited ultrasound versus, a large number of comprehensive, more expensive tests, with a consultative imaging service, right? And so again, we don't want to discount the utility that those consultative services play. I think there's a huge need for the definitive, very comprehensive answer, but to answer limited questions with limited intent and limited focus, point of care ultrasound is really the place to be because we can really get to the heart of that quickly. And I think it kind of gets back to the whole idea of why do you do ultrasound, right? It gives you a better, more specific understanding of what's going on with the patient on your exam, because you can really peel away the skin level and see down into the physiologic level with that ultrasound, right? And so that brings us to kind of the end of the cost portion of it. And I think the general takeaway is that there's going to be probably, depending on how it's utilized and if it's utilized appropriately, going to be some degree of cost savings that's applied or that's gained through ultrasound, right? Which takes us to number two, the second way of increasing value to patients, and that is with the quality of the care that's rendered, right? And this is going to be this is a challenging one to talk about because it's really broad. What does quality mean? And I've been trying to think about that, in my own personal practice, like how do I measure quality? And actually, one of the things that I was thinking about is how do I measure the quality of physician performance, right? And as I've kind of dug layer after layer, have come to the conclusion, and not definitive conclusion, I'm still thinking about it, like it's so hard to measure because what aspect of physician performance do you measure, right? And when it comes down to quality, what aspect of quality do you measure, right? It's hard to say. Medicine is so broad and so varied that it's hard to kind of get to that answer. I mean, think about it in the aviation industry. Did you land the plane? Did everyone survive? Yeah. And was it a comfy landing? Right. It's a lot of things that go involved in that, but like there's some metrics that we can put around that may be a little bit less definitive to answer here, but let's kind of dive in nonetheless. And the case that I want to bring up here is one that we had not too terribly long ago. And it's basically a patient that was walking and fell and broke their hip. Right. And so you can see here the hip and the pelvis view, you can see a femoral neck fracture. Right. And so orthopedics is called, they want to do a surgery to fix that hip. Pretty run of the mill, ED/surgical service patient, right? They get admitted, they get the surgery the next day, everything's good. But there's one thing that we've been working on lately, and we want to increase what we do, and that is providing appropriate analgesia to the patient, right? And so in this situation, a quality metric, among other things, is was the patient comfortable for the period of time from injury to when they got their hip fixed, right? And so traditionally, this is done through various forms of enteral and parenteral medications. But one of the things that's kind of emerged in the literature is, can we do nerve blocks for these patients? And so my colleagues and I did a nerve block on this patient. We did a fascia iliaca block. We were able to depot some anesthetic in there. And the patient appeared a lot more comfortable afterwards, right? He was able to kind of, shift around in bed without significant pain. And what the literature has been showing is that compared to parenteral analgesics, nerve blocks actually help patients, right? And so let's dive into some of that literature here. So this was a study that was done in 2007, published in the Journal of Anesthesiology. And it basically was looking at the fascia iliaca compartment block for acute pain control in hip fracture patients. So seems to be the cohort of patients we're talking about. But what they did is that they found patients. It was actually an interesting study. I think it was a Danish study, which has nothing to do with other than providing some interesting context, right? So it was a Danish study, and they said, okay, people presenting to the emergency department who have findings concerning for hip fracture, we're going to take them, right? And we're going to randomize them to either getting parenteral medications, or, which was, I believe in the study, IM morphine, or we're going to do a fascia iliaca compartment block, right? And they did it before imaging, which I thought was really, 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 really unique, right? And then if you just didn't happen to have a hip fracture, it's like, we'll throw you out. We don't need you because we only want to see hip fracture people. But they basically gave them a fascia iliaca block and a saline depot of placebo in their rear, or they got a saline placebo fascia iliaca block and a depot of morphine in their rear, right? And then they're taking an x-ray, got their films, good. We found the people who had hip fractures. Most of them did, like their clinical acumen was decently good. A few of them didn't, so they got thrown out. And then they evaluated kind of how this affected the patients, right? And what they found is, you can see some of these charts here, that they evaluated pain based on this visual scale, or they said, here's my pain, right? So you can see in the patients who got the fascia iliaca compartment block, the FICB, the pain went down substantially, right? And the people who got the IM morphine, it really didn't change much. Now, interestingly, the people who got the fascia iliaca block reported higher degrees of pain on the initial assessment, which is kind of interesting. Don't really know how to explain that one. And that was when you're at rest. When you take it with movement, right? They kind of had this protocol for how they're going to move the hip around and be like, did that hurt? And how much did that hurt? And then we're going to do that a couple times and see if it gets better over the course of your study here while you get these medicines, right? And they found that the people who got the block had substantial increase or decrease in their pain with movement, right? So that chart that's in the middle of the slide there, you can see their pain score went from 9 all the way down to, a little bit below, was that about 6, so 5 and change, right? Versus the people who had morphine, it went from 9 down to about 8, right? So you had substantial pain relief when you have to move the patient's legs around. And what we know is that, you're not going to be doing the surgery in the ED, right? So the patient's got to move, right? They got to move from the ED bed to the hospital bed to the OR table. They got to shuffle their weight around over the course of the night. Like, there's a lot of movement that happens, even though they're trying to stay still, right? And so providing the fascia iliaca block allowed them better pain control as a result of the procedure than if they just had the standard regimen of parenteral pain medications, right? Now, the other thing, so this was at the outset, and then they kind of got put on a regimen, and they measured a few other parameters. So what were the pain scores that went down, right? What was the opiate use, right? So subsequent opiate use over the rest of the night, it went down, right? And then they also measured, your pulse ox, right? And the pulse ox for patients who got, just opiates alone kind of tended to sag a little bit compared to people who got the fascia iliaca blocks. So they were able to maintain better SATs. And so if you think about this, I mean, all of it makes sense, but we extrapolate it to our patients. People who fall and break their hips, who are they, right? They're people who tend to be in their 50s, 60s, 70s, 80s, and 90s, right? As that age range increases, right, we add comorbidities. You generally don't get older and decrease comorbidities. And so as we add comorbidities, we increase the risk that they're going to have side effects to their medications, right? So if you have renal insufficiency, are you going to clear your opiates? If you have respiratory disease, are you going to be able to maintain your respiratory situation such that you can tolerate having a sedative and a respiratory depressant on board? And then even like the whole idea of ICU or hospital delirium, right? Opiates are going to be a contributor to the delirium that you may face while in the hospital. And so all of these things are benefited by not giving the opiates. And if we can do something instead, fascia-iliaca block, that improves all of those different things, right? So that's interesting. That really definitely hits that quality thing. If we go to this next study, right, this was done in the Journal of Orthopedic Surgery in 2016. And it was a study, I think this was done in the UK. Yeah, UK. And they basically took patients who had femoral neck fractures. So they were a little more stingy in terms of who got in the study. The other one's like, anything in your hip, right? Basically showed that or they did the fascia-iliaca blocks compared to otherwise or other analgesia, and they basically, I think it was parental analgesia, and I don't remember the agent that they exactly used, but it's an opiate, and they basically showed that there was a substantially larger decrease in this visual analog score for their pain when the fascia-iliaca block was used compared to the standard analgesia. So if we look in the table here, you can see with rest and movement, everyone starts at about that 8 to 9 pain level at time 0, right? If you have the block, you go down to about 4. If you have the wait, I said that wrong. If you have the standard analgesia alone, you go down to about 5.5 to 6. If you have that plus the block, you go down to about 4. So the block adds extra analgesia to the patient that wasn't there had they not had that block, right? And so what they found, some of their numbers were a little bit hard to find in the tables, but they reported out in their discussion that, and they listed it in the results, that the patients who had the block experienced a 66% decrease in the amount of opiates that were used while in the hospital for these preoperative, stay, right? And so I think this is an interesting one that, it kind of goes along with the other one, saying, hey, look, if we can do these things, it decreases the patient's pain, but also decreases their reliance on other things that are going to increase the morbidity of the patient while in the hospital, right? And so kind of benefits to blocks, right? Increased pain control, decreased opiate utilization, improved O2 sats. One of the articles said, you could kind of imagine if you do these things, right, you may decrease your, pneumonia rate, you may decrease your hospital length of stay, things like that, because you're controlling for some of these secondary consequences. One of the articles said that they did not necessarily find those changes as a result of their studies, but it seems plausible. If you're decreasing your respiratory suppression, perhaps a larger, more well-powered study would show that there's going to be a certain cohort of patients who will have fewer pneumonias as a result, right? And so things that will be kind of helpful in secondary effects, right? So I think as it comes to improvements in quality, right, we've shown that blocks or point of care ultrasound here can decrease pain, decrease secondary complications, and improve the accuracy, right? It can make you better at what you do. And so what we say, or what I've said, and some of my colleagues have said when we're teaching, particularly ultrasound guided procedures, is if you can do a procedure blind, you can probably do it better with ultrasound, because that ultrasound is going to show you specifically where you're going, right? You can watch in the scenario that I opened with here. I was able to watch the needle go into the skin and sub-Q, and instead of relying on just feeling a pop and a pop to get through your fascia lata and the fascia iliaca, I could say, nope, I'm watching it go beneath the fascia that I want it to go to. And then what we did is we just gave like a little bit of a hydrodissection with saline just to show, yep, we're underneath the fascia where we want to go. Now we can plunge it in. Whereas if you don't, you can still get it done, right? There's a lot of times procedures have been done before, but you just get it done with that better degree of specificity. And they, what was interesting is that first study, the 2007 study, they did those blocks blind, right? They just based on landmark techniques. And they showed there's a certain failure rate to the procedure. And I have to believe that if they added ultrasound to that, that failure rate would have gotten smaller, and a number of patients would have had better outcomes as a result of that fascia iliaca block. So that is quality of care. With that said, let's move on to the efficiency of care and kind of wrap things up here with this one. So imagine yourself working in the ED. I don't have to imagine, this is my case. I saw it, right? And a patient comes in with flank pain, right? And so this particular patient said, hey, I think it was her left side was hurting. And it wasn't a typical patient that you'd expect to have flank pain. You know, so it's like, oh, interesting. This is a younger patient, kind of in their teenage years. And so did this study, right? Examine their kidneys. Left kidney shown on the right-hand side of the screen, right kidney shown on the left-hand side of the screen there. Both look pretty normal. Kind of bummed, but kind of what I was expecting to see, right? Go down to the bladder, and now what do we see? Or what do you think, right? Large bladder, right? And you see kind of off to that right-hand side, the patient's left-hand side, right, where that ureter seems to enter into the bottom portion of the bladder there, you see a bright white spot. So to me, that looks like a little bit of a renal stone, but let's confirm here. So throw a little bit of color on, we get that twinkling artifact, right? And that confirms to me, this is a renal stone, right? And so take the whole story, right? Say, okay, I got a patient who's got sudden onset severe flank pain, right? I have an ultrasound that shows a left UVJ stone. I know that a lot of stones get caught up at the UVJ. I think the cause of their flank pain is a renal stone, right? And you can even measure that thing. I don't think I have the measurement here on this slide, but you can measure it and kind of get rough estimate of how big the thing is, and say, hey, look, let's assume it's 4.5 millimeters. I think we've got a decent chance that this thing will pass on its own. Let's give you some pain control. Let's send you home. Guess what? We just saved the patient a CT scan, right? We didn't have to do that CT, which means we were able to get that patient through, save them the cost, but also get them through the department a little bit faster, right? And so we got some literature that actually kind of corresponds with this. So here's a study that was published in the Scandinavian Journal of Trauma and Resuscitative Emergency Medicine in 2022 by Wang and colleagues. And it basically was earlier point of care ultrasound, shorter length of stay in patients with acute flank pain, right? And so this was a retrospective study that was performed in Taiwan, right? Is looking at the point of care ultrasound for acute flank pain. And they said, they looked at the door to ultrasound time and the length of stay time for patients who got point of care ultrasound done in less than 120 minutes and patients that got ultrasound done in more than 120 minutes, right? So if you got it done earlier, what does it do to your length of stay, right? And they found that the earlier point of care ultrasound was associated with a shorter length of stay. And I'll show you the stats here in just a sec. Back up. They showed that the earlier point of care ultrasound was associated with a shorter length of stay for these patients and for all comers. The problem is, they didn't really define why you had ultrasound done early and why you had done it late, because they have this way of adjusting for potential like waiting room times, right? But here's basically the numbers, right? The length of stay mean for the POCUS in less than 120 group was 146 minutes. The length is that was the total time or total number of patients, 146 minutes. If you got the ultrasound done in less than 128 minutes or less than 120 minutes, it was 128 minutes. And if you got your ultrasound done in over 120 minutes, it was 217 minutes. So a lot of like number soup there, but basically it shows all comers 146, POCUS 128. If you got your POCUS late, it was 200 minutes, right? So they showed that if you got your point of care ultrasound done, right, early, you shave time off of your stay compared to everybody in the study, right? Okay, that's interesting. If we go to this study, the World Journal of Emergency Medicine, published in 2016, this is a study that basically shows point of care ultrasound versus radiology department pelvic ultrasound on emergency department length of stay, right? And so as a prospective convenience sample in the ED, using POCUS versus radiology ultrasound to evaluate patients with pelvic complaints, right? And so this included like pregnant and non-pregnant patients. And what they basically did is they said, okay, you come in on this day, you get the POCUS arm. You come in this day, you get the radiology arm. And we evaluated and see, is there a time comparison? And they basically showed time to completion of the ultrasound favored the ultrasound or the POCUS group by 66 minutes, and total time in the ED favored the POCUS group by 120 minutes, right? So you stayed 2 hours longer if you had to wait for a comprehensive study. And if they narrow that down to your pregnant patients, right, they found that the time to completion was still about an hour shorter, right, with POCUS. Your total length of stay was only about 45 minutes shorter in your POCUS group, but it was shorter nonetheless, right? And so what we can see is when I can do a study myself, right, and get the answer that I need, and admittedly, for most of these patients who are pregnant, all I need to know is, do they have an IUP? What's the heart rate? And what's their approximate gestational age, right? Assuming no heterotopic risk factors and other things. Go to see some of our other lectures for those discussions, right? If I can see the patient, do the study while I'm seeing the patient, and then walk out, find their RH status, I can get the patient out a lot faster than if I have to walk out, order up a study, put that patient in queue to get that study done. Once the study's done, put the patient back in queue to get that study read, and then get the answer, right? And so it seems plausible and seems reasonable that adding point-of-care ultrasound is going to shorten up length of stay when that ultrasound is done appropriately. And obviously we can say there's sometimes I need to have the comprehensive study. This discussion is not about when that time is, but when you can do the point-of-care ultrasound, you shorten things up, right? And a third study to kind of go along with that, point-of-care ultrasound is associated with decreased length of stay in children presenting with soft tissue infections. This one was done in the Journal of Emergency Medicine in 2018. So again, we're looking at 3 different modalities of ultrasound. And this is a retrospective study of kids, skin and soft tissue infection, comparing radiology ultrasound to point-of-care ultrasound. And they basically showed that for all patients, POCUS shortened things up by about 73 minutes. For patients that were discharged, POCUS shortened things up by about an hour and a half. And for patients who were admitted, POCUS shortened things up by about 40 minutes, right? And so despite some of the limitations, demographic differences, things that you see in the cohort groups in these things, there is a solid trend in this study and across the other studies showing that if you can do the bedside ultrasound, you can probably get a result faster and get the patient disposition faster, right? And so based on the available data, my summary here is it appears that point of care ultrasound does improve length of stay in the emergency department, right? And it's for a number of reasons, right? You get a shorter time to your definitive diagnosis, right? So you can make your diagnosis, make your disposition. You do not need to wait for consultative imaging, right? Performance, and you don't have to wait for consultative imaging interpretation, right? And so the implications that this then has is that it increases provider satisfaction, or patient satisfaction, excuse me, because they're out faster, right? Nobody wants to come to the ED and spend their entire day here, right? There's 2 places that I really don't want to have to go. It's the ED and the Apple store, right? Mostly because I spend my entire day waiting for tech support at the Apple store. In the ED, because it just takes a while, right? Even if you can kind of shortcut things a little bit, by being one of the insiders, right? You still have to wait for the stinking test to come back. And so it takes a while for things to happen, right? Nobody wants to sit and wait for that if they don't have to. And so to the extent that we can get people out faster, it improves their satisfaction in the ED, right? Increasing patient throughput in the ED also has a benefit to the hospital, right? The hospital administrators like it because they say, okay, I have this room, right? And I have a certain number of those rooms, and it costs me a certain amount of money per day to keep that room open, right? I have to pay for the providers to staff it. I have to pay for the people to clean it. I got to pay for the lights to be in it. I have to pay for the heating to warm it up. I got to pay for the linens on the bed and all the supplies that go in that room. So it costs me X many dollars per day to maintain this room available for patients, right? So if I can put a patient in that room every hour, right, I can get a certain amount of money out of that compared to putting a new patient in that room every 2 hours, right? You can theoretically double the revenue that you receive as a result of increased throughput. And it also has an effect on decreased ED boarding and ED crowding, right? And so if I can get patients out faster, they're not stuck in my department waiting, right? And if they're not stuck in the department waiting, then I can get that person in the waiting room that needs to be in that room into that room and get them seen, right? If I can get people out of my department because they're admitted faster, like I make the decision to admit and they can get them up faster, I can get someone else into that room who needs to be seen. And we all know, right? The statistics show that increasing crowding and increasing boarding substantially decreases the quality of care that's rendered, just because providers are tied up, rooms are tied up, we can't get the people in that we need. The people that are in are kind of overwhelming the resources that we have. And so I think it's a win-win for everybody. If you can get out faster, you can save the patient time, you can save them probably some money with the increased productivity with the things that they do throughout their life. You can increase the hospital's revenue without really increasing the cost burden to patients, right? And you can decrease boarding and crowding, which increases quality, right? So huge implications for time savings with point of care ultrasound and second and third order consequences down the line. So a lot that we just talked about, kind of big picture things. We don't really love talking about billing and implications a lot, but I think it's important for us because as we think about what we do, right? We certainly want to provide value to the patients, right? We want to justify why we're doing something else to them to make them better, right? And if we get back to that whole idea of what is the point of what we're doing, I mean, we have a very unique job. We practice in a huge amount of complexity in the medical system. What is our ultimate goal? Our ultimate goal is to contribute to flourishing of our patients, right? As we, as providers kind of sit and think through what we're doing. And so I just, wanted to end with this, just put up a bunch of pictures of a bunch of people. I just went on to a kind of a royalty-free, image sharing service yesterday and just look for pictures of people from all over the world, right? There's a ton of people out there who all value something, right? And I just try to find pictures of people that are happy, right? In their environment, right? They all value things in their life, right? And our purpose or our goal is to help them, be a partner with them to continue enjoying the things that they enjoy, right? To help them with the flourishing or human flourishing and to provide value to them in the care that they get, right? And I believe, based on what we talked about and based on the experience that we've had here, that ultrasound can be a huge piece of that, right? We can use this tool, right? And it is a tool, right? To be able to help better understand the patient, right? To more specifically diagnose the patient and to more accurately intervene upon the patient so that we can make things safer, right? Make things more cost effective and of higher quality. So with that being said, I'm going to open up the floor to anyone who has any questions, comments, or concerns as we kind of wrap things up here. And then if not, just encourage you guys to go out and learn this tool, learn how to bring this tool to the bedside so that you can bring these effects to your patients, each and every day. So with that being said, questions, comments, concerns, open the floor here.